to share platform with such eminent faculties. Antimicrobial stewardship is not a new to healthcare community, but it requires reinforcement and regular updates. To begin with, firstly, I'd like to call upon Dr. Unmesh Upadhyay, President Academy of Pediatrics Ahmedabad, for a welcome note. Dr. Unmesh Upadhyay, please.
Thanks, Dr. Mitul. Good evening to all. On behalf of Academy of Pediatrics Ahmedabad, I welcome Dr. Tushar Patel, sir, President AMA, and Dr. Urvesh Shah, Secretary AMA, and today's faculty of Antibiotic Awareness webinar, Dr. Atul Patel, sir, and Dr. Baldev Prajapati, sir, and all participants. Thanks to Dr. Pragnesh and Swasthya Setu to provide a technical platform to organize this webinar. And now I invite Dr. Urvesh Shah to further proceeding. Thank you.
Thank you so much, Dr. Unmesh sir. Now I'd like to call upon Dr. Urvesh Shah, Secretary Ahmedabad Medical Association, to say a few words and start the webinar in motion. Dr. Urvesh Shah.
Thank you very much, Dr. Unmesh and Dr. Jasani. So here I start my presentation with some introduction about AMR. Let's begin with, first of all, welcome you all on very last few hours of the Antimicrobial Resistance Awareness Week. That's 18 to 24th of the November, which is declared by the WHO. This year, the theme is something different. Here, we want to aware the public as well, not only the doctors, but we want to aware the paramedical staff as well as the public. I don't need to explain much more about the AMR. AMR is bugs when this infection causing bugs get added to the antibiotic and making very difficult to be treated. But what we want to highlight here, remember what our Indian scenario is when we are getting the acquire the bacteria from the environment for say due to either unhygienic practices. આપણે કહીએ છીએ ને કે ભાઈ બહાર પાણી પીઓ તો આપણે તો ઇમ્યુન થઈ જઈએ એનાથી, right? So remember this, the spread of this bacteria by which not we are getting so much immune, but yes, definitely it provides the chance to get this bacteria to get added to the many more modalities what we need to treat them. So WHO specifically highlighted few things because it is now going to a very big global public health issue. In the year 2019, it has been documented that almost 1.95 million deaths was due to this AMR, and it's going to be rise in very extreme level. And definitely, even though it is not trolling the life, but it obviously causing the length of the stay, hospitalization, and expenditure much more higher. So here we are talking about the AMR as a global threat. Just highlighting the few things, how it happens, and then we will discuss in further detail by our experts. This is my article almost more than a decade back when I hypothesized how this hospital-acquired infections are getting the MDR. And this is the hypothesis which is now going to be a fact for even community organisms. Very fastly moving that, the story begins with the acquisition of any organisms into the body, right? Usually if it is causing infections, then get treated or being transmitted to the another person, that's okay. But this acquisitions, either maybe due to the fecal oral route or by the contact, this is a common organisms, what we are thinking about as a MDR, they are mainly transmitted by the contact, by the respiratory route or by the GI tract, right? So by that, either they are causing infections or many times they are being colonized. Whether they are infecting organisms or colonized organisms, when get exposed to the antibiotic, definitely out of those populations of bacteria which are susceptible, they are going to be killed by the antibiotic, but those who are resistant will survive and will get chance to replace these susceptible organisms, either being infected or being colonized. And these are shedded into the environment or they are causing the cross infection. This survived resistant organisms when acquired into the another individuals, again, either they are causing infection or colonized, And when they are getting exposed to the second antibiotic, again the resistance organisms which are resistant to the second also, they will survive, they will dominate, they will shed into the environment, and they may cause the cross infections. So such cycles will go on, and along with this, some gene transfer mechanism will add on the more difficulties, leading to the development of the multi-drug resistance bacteria. So here, what we are highlighting, there are the two things most importantly. One is a cross infection, and second one is the antibiotic usage, which are giving rise to the development of the AMR problem. So two key factors which are responsible for development of the AMR, which we need to target, is antibiotic usage and cross infection. As already I have mentioned, the cross infections mainly we are talking about which are transmitted by the fecal-oral route, or which are transmitted by the respiratory route, or which are transmitted by the contact, which can be prevented. See, in this last week we have conducted lots of the public awareness program, as well as we have conducted the program for the awareness in paramedical staff, where we are mainly targeted into the prevention of the cross infections by highlighting the things like hand hygiene, by highlighting the things like having a good hygienic practice for the food, by highlighting the things like having etiquettes for the cough. So this cross infection, if it is reduced, then definitely it can reduce the chances of development of AMR. But what we are today targeting is the antibiotic usage. Yes, antibiotic usage, irrational usage of antibiotics is a big issue. This is a fact. This is a global fact that the 50% of the patients receiving antibiotics did not require antibiotic therapy at all, but still it is going on. Mainly due to the availability of the antibiotic over the counter. It is also responsible due to the antibiotic prescriptions by the many of the unqualified doctors who have never read about the microorganism antibiotics.
At Tata Tiger Reserve for the workshop.
Sorry. So that's the thing, right? And again, in 50% antibiotic, where it is recommended, almost 50% of them, which are infectious organisms, which are resistant to them. So only 25% of the infections are getting the proper antibiotic. Again, that 50%, in those of them, the 50% can be treated with the even narrow spectrum antibiotic. So finally, right now, this is a global scenario, only 12.5% are receiving the proper antibiotic. So what we are targeting today, in today's presentation, we are not targeting the situations like this, the septic shock, where the first hour is very important, where whichever antibiotic you are prescribing, hard hit, it's very well accepted, because the first is a golden hour where antibiotic prescribed whichever is okay. But what we are targeting to the scenario which was predicted in 1974 by the one scientist, that is the compulsory antibiotic prescribing, right? So that's one kind of the afflictions by the many of the doctors, beginning from the interns through the residency, having a long habits, and due to the many of the reasons. So we are targeting mainly how to restrict the usage of the antibiotic prescribings. We have very good renowned speakers today will highlight the things, how we can do the proper antibiotic stewardship in OPD practice, as well as in specific group of the patients. So it's my humble request, and this is a one try of that the spread the global awareness regarding the proper usage of the antibiotic, and need the change the habits amongst us as well. So this is the final what we spread the messages from the Ahmedabad Medical Association. Use the antimicrobial responsibly. Take antimicrobials as per the advice or the prescription for the qualified doctors only. Prevent the infection by keeping your hand hygienes, and prevent the spread of infections by the adhering to the hygienic food and water and cupping and sneezing etiquettes. So that is my message, and according to this theme, we are proceeding for the further presentations by the experts. Thank you very much, Dr. Mitul. I think we now proceed with our experts' opinion. Yes, Dr. Mitul.
Thank you so much, Dr. Urvesh, for start the ball rolling. Now, to enlighten us, we have got our learned dignitary. Firstly, I'd like to call upon Dr. Atul Patel. Dr. Patel is the Director of Infectious Disease Clinic of Vedanta Institute of Medical Sciences, and he is also the head of the Department of Infectious Disease, Starling Hospital. We welcome you, sir. He will be talking on antibiotics in OPD practice. Over to you, sir.
Yeah, good evening and thank you very much for inviting me to speak on antimicrobial stewardship program. Topic given to me is for outpatient settings and not for the inpatient settings. So what is antimicrobial stewardship program? What we mean by antibiotic stewardship program? As Urvesh has rightly introduced the topic, that this is a process, this is a systematic measurement and the coordinated intervention, and this is designed to promote the optimal use of antimicrobial agents in clinical practice, both in inpatients and outpatients. So this is a process which is continuous and ongoing process. So this is not a single one-time the things that you have to continuously measure, like number of antibiotics been prescribed in outpatients by the family physicians, and you need to have some coordinated intervention with the practicing doctors as well as the monitoring authorities, whoever is monitoring the antimicrobial stewardship activities in that particular area or in that particular districts or in that particular hospital region. And the purpose is to provide and promote the optimal use of antimicrobials, so which includes which antibiotic that you are going to use, in what dosage you are going to use for the treatment of certain infections, which route you are going to use, whether it is an intravenous or whether it is an oral route, and what will be the total duration of administration. So what will be your end point of therapy? So the stewardship program is going to address all these important aspects of antimicrobial usage in clinical practice. So what we are going to achieve if we are promoting antimicrobial stewardship, the primary goal for antimicrobial stewardship is to optimize or to improve the clinical outcome of patient with infections, right? So this is very important. When we are prescribing antibiotics, our main aim is to improve the outcome of the patients, right? But at the same time, the AMS can minimize the important and the life-threatening side effects that you are going to face because of the antimicrobial use, which includes the life-threatening toxicities and the superinfections, especially the Clostridial difficile infection, the superinfection with the fungus, like especially the candidiasis, mucocutaneous candidiasis, and most importantly, emergence of antimicrobial resistance. This is extremely important, and Urvesh has highlighted this the issue in his opening remarks. So let me just give you simple examples how the antimicrobial usage increases the antimicrobial resistance. At our Starling Hospital, like in last 10 years, I am advisor to the Hospital Infection Control Committee. And we took a decision, I think before more than 10 years in our one of the meeting for hospital infection as well as the PNT committee, that we should stop providing quinolones to inpatients, those who are admitted to the Starling Hospital. We are not going to honor the quinolone prescriptions by any doctor, right? And the rationale for implementation of this policy was that the quinolones are extremely important component of the treatment of the patient who has a rifampicin resistance or the drug resistance tuberculosis, right? So these are the very important component. And if we are losing these quinolones for the treatment of MDR-TB, then the treatment of MDR-TB becomes very difficult, the success rate goes down, and patients may require a very prolonged therapy, right? So quinolones are very important constituents of the treatment of drug resistance tuberculosis. Either it could be a rifampicin monoresistance or it could be a drug resistance MDR-TB. The second important aspect, apart from the preserving quinolones for the treatment of tuberculosis, the most important aspect why we make a policy that we are not going to honor any quinolones in our hospital would be the quinolones are very important drug which promotes significant ESBL into the gram-negative organisms, as well as the vancomycin resistance into the enterococci. So this collateral damage that we are going to face by using quinolones in clinical practice is tremendous. You must have the notice and witness that the ESBL prevalence in last 1 decade has gone crazy. Like most of the gram-negative organisms, either it is a simple Escherichia coli, or if you are talking about Klebsiella, Pseudomonas, or the Acinetobacter, all these gram-negative organisms, they are harboring one or the other ESBL enzymes. And your first line, the armamentarium agent is not effective for treatment of this gram-negative. And the promotion of this ESBL is coming from the use of quinolone in clinical practice. So my appeal to all of you as the family physician, that you should also stop prescribing quinolones in your day-to-day clinical practice for the treatment of respiratory infection as well as for the treatment of urinary infection. The reason is the same, because now ESBL we are also getting from the community, and VRE, which was not a problem, is now we are dealing with the VRE infections quite commonly in clinical practice. And the treatment of VRE is extremely difficult. So why we are concentrating, why we are focusing antimicrobial stewardship in outpatient care? The reason is that if you look at the inpatients and the outpatient use of antimicrobial, the most of the antimicrobials we are using in outpatient management of the outpatient care. The inappropriate use of antimicrobials in outpatient care is very common, right? In United States, this is CDC estimate. So this is not our data, Indian data, but in United States, the CDC says that up to 30% of antimicrobials prescribed in the USA clinic are unnecessary. This is what the Urvesh says, right? He said about half of the patient, but in USA, the 30% of the antibiotic prescriptions is unnecessary. And it also mentioned that many more prescriptions are suboptimal. So the dosage that is required for the treatment of the infection was wrong. The wrong choice of antibiotic were given, and it was given for a wrong duration, right? So this is not common to the India. This is a global problem, and we need to improve. We need to educate ourselves. We need to understand the value of antimicrobial stewardship and use antimicrobials rational, right? So in OPD practice, this is a critical target for antimicrobial stewardship program. That's the reason that we are focusing more on AMS in outpatient care. So what are the core elements of the outpatients AMS? These are almost similar to the inpatients antimicrobial stewardship program, but inpatient, like the hospital, the CEO or the hospital, the chief medical administration, this is a very crucial component for running effective AMS in inpatient care. But in outpatient care, the mainly like we need a commitment from a participating doctors group. So they have to demonstrate a dedications to and the accountability for optimizing antimicrobial prescriptions and improving the patient safety in their clinical practice. So unless like all of us are, the come together and demonstrate a dedication that yes, we would like to do, we would like to run effective AMS in our society, then and then like we will be able to start the antimicrobial stewardship. At Stirling Hospital, we have forced clinicians that you are not going to receive quinolones. Like, so even though they are prescribing levofloxacin, moxifloxacin, they are not going to get. They have to use the alternate therapy. So this was by force, and this force was because of the hospital administration. We could convince the administration that this drug is harmful and we should not use in the inpatients for the management of the common infection. It should be reserved for tuberculosis, non-tuberculous mycobacteria, and certain other indications. So commitment is very important for outpatients antimicrobial stewardship program. The second important thing is we need to have a clear-cut policy. For example, like I told you about the quinolone in the clinical practice. So we need to develop and design some policy and start practicing into community, right? So implementation of this one policy and try to, improve the antibiotic prescription, because this is not from day one, like, because when we are using quinolones regularly or routinely in our clinical practice, it's not possible to stop quinolones from day one, right? So it's a gradual process. It's a slow process. And so if we are developing this policy, we try to monitor this policy, we try to assess the effectiveness, whether it is working well or not. And we may modify, like if it is not working well or we are not getting a great results, then we may modify this policy. So this is second important core component of antimicrobial stewardship. The third important thing that we need to identify the high priority conditions. What are the areas that we are going to target for antimicrobial stewardship program? Right. So there are some examples. So we are going to discuss these examples again in subsequent slides. But there are a few conditions where the antibiotics are not indicated, right? And the most common indication would be acute bronchitis. And I mean, we all know that this is a season for acute bronchitis. So patients may come with the cough, which could be a dry or which could be some scanty or the productive cough. So this acute bronchitis, I mean, they do not require antibiotic therapy. The common cold, simple running nose, nasal blockage, so URI symptoms. I mean, these are the patients who do not require antibiotic. Other non-specific upper respiratory infections, viral pharyngitis, and asymptomatic bacteriuria. I think, I mean, this is very important indication. Again, we are going to, I mean, discuss. So in these conditions, like we should stop using antibiotic for treatment of patient who presented to us with this condition. Another important core elements would be the tracking and reporting. So once we have made some policy, once we are trying to implement it, then the policy, like whatever the measures that we have put, we need to do an audit and get a feedback from the doctors, those who are participating, and how they are feeling, what are their response, how their patients are, I mean, responding as compared to the previous their routine practice. So this is, I mean, we need to audit and get a feedback from the practicing doctors. So this monitoring is extremely important because this will help you to improve your policy and your subsequent steps. And the most important core component is education and expertise. This is what the IMA is doing, right? So we need to provide all the educational resources to our practicing doctors. And if possible, we need to educate patients on antimicrobial prescription. This is very important. So we need to give all the latest important guidelines or the summary of the guidelines for respiratory infections, for the urinary infections, for intra-abdominal infections, or the common infectious conditions to all the practicing doctors, and educate them and like improve their understanding and reducing the antimicrobial prescriptions. So again, coming back to the area which are very important and we need to identify for AMS or the antimicrobial stewardship. So there are certain areas where the antibiotics are not indicated and we are using antibiotic for treatment of these conditions. So that we have discussed acute bronchitis, non-specific upper respiratory infections, viral pharyngitis, right? So there are some conditions where we overdiagnose, like group A streptococcus pharyngitis. This is very common. Unfortunately, like we do not have a rapid diagnostic test for group A strep pharyngitis. Otherwise, like, I mean, the diagnosis would become very easy and you may be able to provide appropriate antimicrobial for group A pharyngitis. So sometimes like the viral infections may produce exudative tonsillitis, say for example, Epstein-Barr virus, or the acute infectious mononucleosis, which generally mimics like the bacterial infection because of the lots of exudates that you are going to get from the tonsils. Tonsils are enlarged. You will see the red, angry, the pharynx. So all the features, I mean, probably mimics like a bacterial infection. But if you are using a rapid diagnostic test to confirm that this is the strep pharyngitis, then probably antibiotics are indicated. The another important overdiagnosed condition, and this is true in Indian condition, is urinary tract infection. I have noticed that many times, like when patient is having a fever, but patient do not have any urinary symptoms, and the urine examination showing 8 to 10 pus cells, frequently this patient is being labeled as a urinary tract infection, and patient prescribes antimicrobial therapy. And after a certain time, like again, urine is repeated and again, urine is showing some pus cells and again, the repeat course of antibiotic has been given. Remember that when patient is having a pyuria and patient does not have any urinary symptoms, the urinary symptoms, which I mean is that the burning, frequency, hesitancy, urgency, pelvic discomfort. So these are the symptoms, right? And the fever, right? So if patient do not have any urinary symptoms and patient is having pyuria or asymptomatic bacteriuria, meaning that if you are ordering urine culture and the culture comes positive for E. coli or whatever organisms, but patient do not have any symptoms, patient do not have any urinary symptoms, or patient does not have any fever, then you should not treat this patient who has asymptomatic bacteriuria unless the urosurgeon is performing some urogenital interventions like putting a stent or removing a stone, or any other bladder examination by endoscopy or doing some biopsy procedure into the urogenital tract. So these are the areas where, even though patient is having asymptomatic bacteriuria, the antibiotics are indicated. And the second place where the antibiotics are indicated would be the patient who has profound immunosuppression, and patient is likely to get the patient is having a fever, and the patient is having asymptomatic bacteriuria, and patient is having profound immunosuppression. So here also, like, probably you are going to treat, and the pregnancy. So pregnant patients with asymptomatic bacteriuria, probably we are going to address by providing appropriate antibiotic therapy. So there are 2 or 3 important indications where we are providing antibiotics for asymptomatic bacteria, mainly two. One is urogenital intervention and second is pregnancy. But profound immunosuppressions like liver transplant or kidney transplant patients, or the patient who has some stent inside the ureters where you are worried about the stent colonization, stent infection. So very few selected conditions where you are going to prescribe antibiotics. Otherwise, asymptomatic pyuria or asymptomatic bacteriuria does not require antibiotic therapy. There are other examples of wrong agents for wrong dose and the wrong durations, like azithromycin is very commonly used for bacterial sinusitis, and ideally the beta-lactam or the penicillin should be used for the sinusitis, where you should avoid using azithromycin. Even for pneumococcal infections, either the middle ear infections or the otitis media or the sinusitis because of pneumococci, many times like azithro is being used. Ideally, you should use penicillin or the beta-lactams. And the patient who actually requires like otitis media because of the strep pneumonia, here like you have to provide appropriate antibiotic therapy, and many times like the clinicians are not prescribing, looking that this could be just simple viral, and here like watchful waiting is not permitted, and you should give early antibiotic therapy. So looking at the international data, like coming to our Indian reasons for antimicrobials prescribing. So apart from the urinary finding a pus cells into the urinary system and providing antibiotic, the another important common conditions where the antibiotics are widely misused is serum Vidal. And many times, like patient may not have high grade fever, patient is having just 99 fever or very low grade fever for several weeks, right? And the Vidal comes positive, and patient is falsely labeled as patient is having typhoid fever, and patient is being prescribed broad spectrum antibiotic to take care of this enteric fever. So this is wrong. Like if you look at the clinical presentations of typhoid, it is always a very high grade fever. Patient can have headache and other constitutional symptoms like body pain, back pain. Patients can have abdominal symptoms, either like diarrhea, or patients can have constipations in begin with. And this fever, the most important thing is this fever is very high grade. And if you carefully take a history of a patient who has actual typhoid fever, you will find that it is a step ladder type of fever. So daily the fever temperature increases incrementally, right? So if patient is having 99-degree fever, I think you should avoid making a diagnosis of typhoid fever. And one more request, that Vidal test is useless for making a diagnosis of typhoid fever. I'm again telling you that Vidal test is useless. You should stop practicing or requesting Vidal test to make a diagnosis of typhoid fever in your clinical practice, right? If you are suspecting typhoid fever, please send a blood culture. And the sensitivity of blood culture is more than 80%. So if you are sending a blood culture in a first week in a patient who has typhoid fever, it's going to come positive. And look at the sensitivity and the specificity of Vidal. The Vidal sensitivity is ranging from 18% to 28%, and the specificity is again ranging from 7 to 20%, right? So it is highly the useless test for making a diagnosis of typhoid fever, while the blood culture has the highest sensitivity in the first week, and it is very specific. So there is no reason to doubt that patient is not having typhoid fever when your blood culture comes positive, right? So please stop doing Vidal in your clinical practice, and that will probably reduces markedly the use of antimicrobials in our day-to-day clinical practice. In fact, like just before Corona, I was talking to our ICMR director who was in charge of this communicable disease and infectious disease, that if we want to run a good AMR in India, we should ban serum Vidal in India. Just like we have banned TB, IgM, and IgG to make a diagnosis of tuberculosis, we should also stop doing serum Vidal, because this is an investigation where the clinicians are tempted to provide antimicrobials to their patient who has just 99-degree fever, right? So apart from this serum Vidal and the misuse of antimicrobials, there are several occasions where the patient who has confirmed dengue, either NS1 positive or the PCR positive, or the patient is chikungunya and the malaria, they also receive antimicrobials. So these viral infections like antimicrobials have no activity against any viruses, right? So we should avoid when you have confirmed diagnosis. So this is what we need to develop some courage that, look, this is dengue fever and I'm not going to prescribe anything to this patient except paracetamol, rest and hydration and some B complex. For chikungunya, same thing, right? For malaria, give antimalarials rather than providing antibiotics. We have witnessed like many of the COVID-19 patients and influenza patients, they are receiving antibiotics like in this COVID pandemic time. So this practice we should also stop to improve the antimicrobial stewardship. Urine examination, we have already discussed. The quinolones we have already discussed. And apart from that, like for typhoid fever, we are overusing cefixime and other antibiotics in day-to-day clinical practice. And one more reasons where the Indian clinicians, they do prescribe antibiotics is they are chasing WBC count. And many times, like they are not looking at the differential count, and they just simply chase that count is now 15,000, goes increase to the 17,000, and now again it is 14,000. So patient requires antibiotics. So they just continue to bombard antibiotics till WBC count reaches to the normal. So do not chase WBC count. If your patient is stable, patient is asymptomatic, and patient do not have any symptoms, please just monitor clinically. Do not give antibiotic for WBC count. Just to support this statement, let me discuss a clinical scenario. The young female, 23 years female, who presented with a throat pain, fever of 101 degree, skin rashes, and WBC count of 16,800. Right. So obviously, like we are tempted that patient must be having some pharyngitis or tonsillitis, and we need to give antibiotic because WBC count is 16,000. Examination showed enlarged tonsils and exudates. But if you look at the differential count of this 16,000 count, it showed a 74% lymphocyte with reactive lymphocyte. So the diagnosis is very clear. This is infectious mononucleosis, 74% lymphocyte, and these are reactive lymphocyte, right? So this patient do not require antibiotic therapy, right? Mononucleosis is just raised hydration and paracetamol. So, and you may, add some gargles, like saltwater gargles for treatment of this patient. So avoid antibiotic, try to look carefully into your WBC count, look at the differential count, and try to figure out whether you are dealing with some bacterial infection or the viral infections. So why we are talking so much about antimicrobial stewardship, why we are promoting the rational antibiotics in day-to-day clinical practice, the reason is that the antimicrobial side effects are very common and we are not reporting. And these are the data from USA, and they say that 1 in the 5 patient who received antibiotic therapy, they experience one or the other side effects. And the most common side effects they have described are 40% of the patient, they have GI side effects, 1/4 of the patient, they have renal side effects, renal toxicities, and 15% of the patient, they have hematological abnormalities, right? So patients are unnecessarily being getting severe side effects. Now, coming to the outpatient use of antibiotic, this is a very interesting paper published before 8 years in OFID, that is Open Forum of Infectious Disease Journal. This is a very prestigious journal. And they have reported that outpatient antibiotic prescribing in a community leads to the community-acquired C. diff infections, right? So 1/3 of the C. diff infections were related to the community-acquired antibiotic practice. And fortunately, like India, do not have a very high burden of C. diff or the Clostridia difficile infection, but still we are seeing in a good number of patients who has C. difficile in inpatient practice. So how we can improve the antimicrobial stewardship? So we have already discussed the core components. That these are the core components where it will help to for the antimicrobial stewardship. But one important thing which definitely helps the antimicrobial stewardship is diagnostic stewardship, right? So the clinician's confidence comes from a confirmed diagnosis. So again, coming back to the Vidal, if you have a confirmed diagnosis, if your blood culture is positive and patient is spiking very high grade fever, that confirms a diagnosis, right? And so that will improve your confidence that you are going to treat this patient with intravenous ceftriaxone, right? So diagnostic stewardship is extremely important. And nowadays, we have many rapid diagnostic tests, just like the rapid antigen test for COVID-19. We have a rapid diagnostic test, or it is also called as a lateral flow assay, which is a bedside test for many infectious diseases, including the invasive fungal infections. And this will help you to reach to a diagnosis very quickly. So, but you have to select a right test for your right clinical syndrome. So if your patient is having, if you are suspecting influenza or if you are suspecting COVID, for example, you can also have a rapid antigen test for COVID, or you can also have a rapid antigen test for influenza. So you have to select a right test for your right clinical syndrome, and it should be done at a right time. What is the right time? Say, for example, if your patient is coming with a fever of 2 days, and patients have very high grade fever, severe back pain, severe body ache, and global headache, and it's in a dengue season, and you are suspecting that these patients can have dengue. So 2 days history of very high grade fever and all the symptoms. If you are sending dengue, IgM and IgG, and if you are not sending NS1 or if you are not sending PCR, then you are not going to get a diagnosis, right? Because this is not a right time to send IgM and IgG for a dengue patient within a first 5 to 7 days time. When the patient is spiking fever, ideally it should be antigen, that is NS1, or it should be a PCR. You have to figure out the presence of the genetic markers of the infectious agents by PCR, right? So you have to apply a test at the right time of patient's clinical syndrome. And again, into the right patients. Once you get a test result, right, the interpretation of the test is very important, right? So many times, like I'm giving you examples of one fungal biomarker, and that is the galactomannan. So many times, like galactomannan comes positive, and the clinicians just put a diagnosis that this patient is having aspergillus. But the interpretation of that test is very important. When patient is receiving BL-BLI, that is beta-lactam is inhibitor combinations like piperacillin tazobactam or amoxicillin clavulanate, you may get false positive galactomannan, right? Because of the use of antibiotics. So interpretation of the test results that you have ordered to reach a diagnosis is extremely important, right? After confirming a diagnosis, you have to administer the right antibiotic. That is what the principles of antimicrobial stewardship: right dosage, right route, and the right duration, right? So this is very important. So diagnostic stewardship will always facilitate, always support the antimicrobial stewardship, right? So diagnostic stewardship is very important. And apart from that, the education and promoting the guideline-based treatment. So try to follow the guideline. Do not violate the guideline. It does not mean that you have to follow guideline very strictly. Guideline will support your clinical decision. Guideline will tell you like what are the important differential, what are the important antimicrobials that you are going to use. If you are treating these conditions with this antibiotic, the chances of success rate would be this, right? So try to take a help from the treatment guideline for the selection of antibiotic and for the duration of treatment, right? And this slide is from the recent ID week at the Boston. I'm using because they have discussed about the antimicrobial stewardship in critical care. So critical care is another important component, just like the outpatient care. And the author interestingly says that it is a fear and not the knowledge deficit that drives the excess antibiotic use, right? So it is our inner fear that if I'm not prescribing antibiotic, patient may have some disease worsening, patient may have some disease progression. So I think you have to come out from this fear, because we all understand like this is viral infection, we are not going to use antibiotic, but the fear will prompt us to prescribe antibiotics. So we have to come out from this fear. And this is what WHO is promoting, what Urvesh says. Just to summarize this talk on antimicrobial stewardship, antimicrobial prescribing in outpatient setting is very common. So education, audit, feedback, decision support is extremely important to promote AMS. The diagnostic stewardship I have already talked about that can improve the AMS, and the social behavior, the approaches, communications is again very important, because sometimes your colleague may have some confusion. So if we are communicating with that, I mean, with this clinical scenario, you can stop antibiotic or you can avoid use of antibiotic. So this communication can improve the confidence of your colleagues. So again, the last, the take-home message would be, we should stop using quinolones in our day-to-day routine clinical practice. Thank you very much for the patients listening.
Dr. Mitul, you are unaudible. Just unmute.
Sorry. Thank you so much, sir, for a nice and very crisp talk. And all those delegates who are viewing us online, I would humbly request them to ask their queries in the chat section. Now, moving on to our next talk. Our next speaker, Dr. Baldev Prajapati, sir, will talk on antibiotics in pediatric practice. Sir is a professor and head of the Department of Pediatric, GCS Medical College. Welcome, sir. Handing over to you, sir.
Greeting friends, I think before I share my presentation, let me express a word of gratitude to these organizers, especially President, my friend Dr. Tushar Patel, and Secretary. I am most lucky that even the very close friend Dr. Urvesh Shah, Dr. Urvesh from IAP, and Dr. Mitul from again the IAP Secretary, and my co-speaker, Dr. Atul Patel, and all the friends those who are watching us and listening to us. I think first, let me congratulate the organizers for organizing such a fantastic and very, I would say, essential program. I'm sure that there should be some effect at the end of this discussion. And I request all the listeners that please just don't listen for the sake of listening. Try to make some decision in your mind that from tomorrow, at least one or two changes I will do. And I'm sure then that this will be the fruitful discussion. And I'm confident that it is going to penetrate our friends in, I will say, in action and behavior. With this, let me share my PPT. Before that, I'm sure that my friend Dr. Urvesh and Dr. Atul Patel has made my work easy. And fortunately, they have not touched the points which we are going to include in my presentation. I hope that my slides are visible.
Yes, sir. Yes, sir.
Okay. I think straight away what I want to take to you, already we learned from these two speakers that undue use of the antibiotics in our outdoor is the biggest issue. And probably if we focus on that area, we can curtail to some extent, definitely. I think we may not go in the discussion of these indoor and critical ICUs, where probably different thoughts are required. And keeping in mind, let me start my presentation that what as a general physician and general pediatrician we can do. Please always try to go in the details of the history. Examine the patient thoroughly. I think some of the points very nicely described by Dr. Atul Bhai, that if you get the history appropriately, then if you examine that there is a yes, sore throat is there, even the membrane is there, but the fever with the rash and lymphadenopathy, I think it's not the bacterial infection. That will, I'm sure that everybody will be clear. And then your working or clinical diagnosis should be affected by virus, then I'm sure that you should not prescribe the antibiotic. So my first request to all the friends, spare some time, go for the details of gathering the information, and try to perform the habit that back of your paper, you will put your clinical diagnosis. And I'm sure that once you say the viral infection, your hand is going to tremor for prescribing the antibiotics. And I think this is the very fundamental basis which all of us should understand. Please keep in mind that antibiotics and the investigations are not the substitution of the clinical diagnosis. Even people have studied that why there is overuse of the antibiotics. Because numbers of patients are more. You don't have the time for understanding or taking the history or examination, and fever or something, probably bacterial, and not to miss anything. And even the fear complex, what even the Atul Bhai was telling, I think these things lead us to prescribe the antibiotics. So I think that's a point which we can focus. Second, always documentation of fever. I think that point was also highlighted by Dr. Atul Bhai, that just fever, if you measure, may not be the significant. Because parents are complaining, and as a pediatrician, I know grandparents will complain more because their emotional expression. But if you measure, may not be the significant. And therefore, the documentation of fever is very, very important. Don't just start the antibiotic from the complaint of the parents that fever is there, very high-grade fever is there. And I think you know that these are the adjectives or the descriptions, narrations of the parents, which probably may tempt you to start the antibiotics. So this is very important first point in documentation. Second, ask the questions to yourself. Is there any other reason for the fever? I think in month of April and May, all of us get the heat fever. That may be the reason in the newborn, even the dehydration fever. And probably these things don't require this treatment. There may be sometimes even the drug fever in the indoor patients, or even the malignancy and collagen. And if these possibilities are there in your mind, don't aggressively, I would say, decide to start the antibiotics. Study the fever pattern, go in the details as I was talking. For unfortunately, now fever pattern is not maintained, but that is also, I think, partly we are responsible. Early startment of the antibiotics and undue, even the antipyretics. Try to define it as viral or bacterial, how I'm going to discuss. Any point of malaria, probably you can go for pap smear examination rather than starting the antibiotics. Suppose there is a biphasic fever, it is highly indicating viral, like dengue fever or leptospirosis or chikungunya. Go for the confirmation. As already it was discussed very nicely, appropriate by Atul Bhai, the diagnostic stewards is important. And if the diagnosis is confirmed of chikungunya, you should remain away from the antibiotics. Single, I will say, isolated fever spike probably may not be due to the organism or the bacteria. Don't start unnecessary antibiotics. From the history, how I can decide this viral infection? You know that the viral infections are disseminated throughout the system. There may be the fever and cough and even the wheezing also. I think in the adults also, Atul Bhai said that acute bronchitis, they don't give the antibiotics. Why the pediatrician should give the antibiotics in a case of, I would say, viral wheezing or even the bronchiolitis? Similarly, you know that there may be the fever, cough, and vomiting and diarrhea. That means multiple system is involved. Even if you go into the details that, sir, the older child was under your care in the previous week, now this child has started, all the family members are suffering. That very indicating, I will say, viral rather than the bacterial infection. And many a times all of us are talking that in the community at present, plenty of patients we are getting. Probably that is viral, not the bacterial. And again, starts with a very high grade fever, gradually comes down, and fourth or fifth day patient may be afebrile. in such a, I will say, very clear-cut story, if any physician starts the antibiotic, I think it's a big issue. We should be very clear that at least we may not be helpful to the patient, but we cannot damage to the patient. And once we decide that yes, it is viral, very clear-cut answer, no antibiotics. And I'm sure that's just simply, if you change your behavior in the practice from tomorrow, I'm sure that the percentage of the antibiotic usage should come down. When we'll consider bacteria, where it localized, tonsillitis, that also the older the child, tender digestive lymph node, I think in that case, okay. But again, it will not be the running nose and the chest signs. Moderate fever at the onset, I think you can wait. And often the child may be even sick during the interfebrile period. Then probably your consideration of the bacterial infection may be, I would say, justified. Dr. Atul was talking very appropriately that this is another area where undue all of us start the antibiotics. Count is high. Many times I get the history from the parents that for what you have come, sir, count is not coming down. Their complaint is not anything else. Count is high. Count is 20,000. Treat the count. I think we'll have to explain that the count is the high count is the good phenomena that body is working. And this leukocytosis may be even a case of viral in the initial phase, maybe even due to stress following the convulsions, not necessarily meningitis, in a children due to the febrile seizures, some child with nephrotic syndrome and the steroids, maybe I will say leukocytosis due to the drug, or even the early neutrophilic count also can be viral. Neutrophilia, not necessarily it is the bacterial infection. And all of us know that even some of the collagen disorders can also present with this leukocytosis and thrombocytosis. So I think once if you ask for the CBC, go in the details of this CBC, go in the differential count and total count, look at the platelets, look at the peripheral sphere. I think that will help us. But simply the count is 12,000, 15,000, 18,000 is not the, I will say, permission to us as a clinician to start the antibiotics. That's not the criteria. Once you decide that yes, it is the bacterial infection and antibiotics is indicated, then which one? Most of the times we start the empirical antibiotics. And here we should know the antimicrobial spectrum of the different drugs. You know that the people are treating this upper respiratory infection, the cefixime. I don't understand. That indicates that the basic of the pharmacology is lacking with us. Cefixime is never working above the diaphragm. Cefixime may work below the diaphragm. Only, I will say, in pediatrics, 3 conditions: enteric fever, dysentery, and UTI. Nowhere else. I'm sure just if we decide this thing in the mind, automatically usage of cefixime should come down. And every pathogen has the first choice. Try to find out which one is the first, which is probably less toxic, basic antibiotic, and probably very narrow spectrum, very effective on the targeted organism. Community-acquired infection does not require the aggressive treatment. That is the another thing which we should keep in mind. And as far as possible, choose the single oral antibiotics. This is also myth not only to the patient, to us also. That parenteral antibiotics works very, very nicely, very fast. I think it's a totally miss. These oral antibiotics also equally effective. And not necessarily we should cover everything gram positive, gram negative, and even the anaerobic. That is also the, I will say, wrong concept from which we should remain away. We should not cover everything. We should cover whatever your targeted clinical organism is there. Before that, find out some red flags. Yes, if it is there, I may not wait. In a patient, suppose without a disproportionate tachycardia, delayed capillary refill, this patient may go in the shock, and here with the fever, I may take the liberty. Of course, a pneumonia or even the sensorial changes in a child bulging anterofontanally, neck stiffness, or signs of the meningococcal meningitis, you may start the antibiotics straight away without waiting. Yes. or even as I was talking of this diphtheria, fever in the newborn, or even the septic arthritis, or even the immunodeficiency where you are knowing. Already when Atul was talking that suppose some foreign substance is there in the body, either in the form of the VP shunt or some cardiac disease, or in the adults there's some stand is there, I think they can use the antibiotics, but not otherwise. And here, straight away with the collection of the samples, you can start it. Or there is some obvious bacterial infection, suppose tonsillitis, that too even the very high-grade fever, toxic child, membrane is there, jiggle diagnostic lymph node is there, and cough is not the prominent feature. I will say here, I will consider tonsillitis in an older child and may start the amoxicillin with the appropriate drug. Acute otitis media is the condition which is probably missed and not even the targeted or treated properly. Acute lymphadenitis, yes. Bacillary dysentery, here straight away we can start the antibiotics. I'm sure that the rest of the conditions you avoid, the usage of the antibiotic should come down. So actually what we should do as a physician, when obvious reasons, suppose as I said, this tonsillitis, lymphadenitis, dysentery, you can start the antibiotics. But fever is there, you don't have the localization, I think here we should not be in a hurry. Wait simply for the paracetamol. In antipyretic also paracetamol only. Not I will say the various funny or I will say novel combinations. Wait for 3 to 4 days. And once you decide that yes, significant fever, documented fever, more than 4 days, I don't have any focus. Yes, that's the time for the clinician to decide that these are the various possibilities which may be the enteric, sepsis, UTI, malaria. Collect the samples for the investigations, and then you can start the antibiotics and devise, I will say, on the investigations. Suppose if you started these antibiotics, but now the P5X has come in the peripheral sphere, go for the chloroquine and stop the antibiotics. I think that's very important. Somehow, as Atul was telling, that this patient will receive both the things, chloroquine and antibiotics. I think that thing should not happen. This is very important message which I would like to convey to you. Empirical antibiotics, as I was talking some of the conditions like HIV, febrile neutropenia, sickle cell, asplenia, nephrotic on the steroids, or severe acute malnutrition, or meningitis if you're suspected, empirically you can start the antibiotics. Otherwise, I think not routinely. Then how we can do? There are various points that probable organism. Ask these questions to yourself once you decide to start the antibiotic. Which is the organism, gram positive or gram negative? What is likely? What is the age of the patient is also very important. Site of infection, yes, that makes a difference. And even the clinical presentation. And if it is community acquired, don't be the aggressive. Nosocomial is a different story. I will not go into the details. And if it is really this, it's a community acquired mild infection, then first line of the drug, and that should be the narrow spectrum for the community acquired. No initial consideration of the drug resistant at all, except some known conditions like MDR, typhoid, or cystinosis. And low potential to develop the resistant drug should be preferred. Amoxicillin is the, I will say, if you use continuously for years together, less chances that the resistance will develop. Similarly, we have the good experience with the cefotaxime. So as far as possible, some of the drugs are your offer choices. Go for these choice rather than the other molecule. As I was talking, oral drug, if it is child is accepting, no vomiting, no any contraindication like distension of some surgical condition, we can go by the oral route. And if parenteral route is indicated, choose one which is also available in the oral. So that after this child is settling down, improving, you can switch on to the oral route. The same drug you can. And no use of the enzyme inhibitor in community acquired infections. Maybe consider after adequate trial of 3 to 4 days change of antibiotics. I know that many times I get the patient that the morning high-grade fever started some antibiotic. In the evening, something else, and second day, 3 or 4 antibiotics. What you want to achieve? Is it so that this by showing this antibiotic, this infection is going to go away? No. We have to wait at least for 3 to 4 days. Before that, you can go for the appropriate choice. But once your, I will say, diagnosis is there, your choice is there, at least give some time to the antibiotics to work. And if at all there is a question comes of second antibiotic, it should be rational, not just higher generation. I will give the example. Suppose if you have diagnosed pneumonia in 5-7 years old child, if you have started either the amoxicillin or cephalosporin group, and after 4 days there is no improvement, I think in that case, rather than going for the vancomycin, if the patient is stable, consider that this may be the mycoplasma. And for that reason, you should go for the macrolide rather than going for the vancomycin or piperacillin tazobactam. I think that should not be the rational choice. Change of the antibiotics means previous one should be replaced. Here what we are doing, we are continuously continuing the multiple antibiotics. Is not the answer. If you go for these, I will say, suppose azithromycin, then stop this with the ceftriaxone. And if at all 2 antibiotics you have used and failed, never go for the third antibiotic. It requires, I will say, that revision of your diagnosis. Something is probably you are missing, or there may be some problem or complication development. In a case of pneumonia, check for necrotizing pneumonia, check for the empyema. I think rather than going for the change of antibiotics. So this is very important and commonly in the practice that makes difference. And I'm sure that if you are following, the usage of the antibiotics will significantly come down. Combination of antibiotics hardly it is required. I will say hardly, I say, even 2 times I will say. And very few conditions, neuronal sepsis, yes, cephalosporin and aminoglycosides, immunocompromise, yes, because here multiple organisms are possible, bacterial endocarditis, yes, intra-abdominal infection, yes, because it is a polymicrobial, maybe the gram-positive, gram-negative, anaerobic organisms. But here, that selection of the combination should be also very appropriate. So that's the point which, and very few conditions practically will have to use it. Once you decide, then combination should also be the rational. Ceftriaxone chloronic acid is never rational. Ceftriaxone and even some more this inhibitor is not the rational. I will say amoxicillin chloronic acid, yes, rational. Ampicillin sulbactam, rational. Piperacillin tazobactam, rational. But very few cotrimoxazole, rational. Rest of, I will say, many antibiotics are absolutely irrational and we cannot use it at all. Cotrimoxazole and beta-lactam are how we can use it. So combination again, judiciously and appropriately should be used. Very important, already we were talking that in the antibiotic, once you decide to use, your diagnosis should be the right one. Your choice of the antibiotic should be the right one. Your right dose should be there, right duration and right route of administration. As I was talking, oral drugs is preferred unless parenteral route is indicated. Yes, there are certain conditions where the oral route cannot be advised. Which one? Acute bacterial meningitis can never be treated by oral route, only intravenous route, not even the intramuscular. Bacterial endocarditis totally 4 to 6 weeks IV route, no oral. Bone and joint, initially IV, then you can switch on the oral. Septicemia and neonatal infections, there is no, I will say, oral route. And switch on therapy, yes. After that, the same drug, sequential, or even the switch on therapy, we can use it. Most appropriate dosage is very important. You know that the homeopathic doses are also dangerous. In a case of enteric, I will say, suppose if you are using the cefixime, it should be 20 milligram per kilogram per day in the child. Other infections, you may use the 10 milligram per kg, but in a case of enteric fever in children, cefixime should be 20 milligram. Ceftriaxone should be the 100 milligram per kilogram per day. So that is also very important. But conditions with the kidney injuries, liver injuries, we have to take care adjust the proper doses where probably we cannot go for the routine doses. Optimal duration. This is also another thing. Initially, probably we are giving that 7 days, 10 days, every condition, not necessarily. On the contrary, where the condition allows you, you can stop your earlier. Bacterial meningitis, 7 days to 10 days, but suppose meningococcal, in 5 to 7 days, you can stop it. Neonatal septicemia and pneumonia, 2 weeks. But yes, meningitis is there in the newborn, 3 weeks and total IV. Skeletal infections, total duration 6 weeks. Endocarditis 6 weeks. Liver abscess 6 to 8 weeks. But the rest of the conditions does not require the prolonged duration. Very important point, friends, please remember. The clinical impact of the antibiotic use, what happens? We should ask these questions to ourselves. What happens to the person, individual, unnecessary early use in the infancy and childhood? As a pediatrician, I think very important my appeal to all the friends, be careful that the child has to live the whole life. And if I prescribe the unnecessary drugs, there is an alteration in the microbiota. And we are learning from the various studies appearing in the journals that all the problems later on what we get in the older children and adults in the form of the allergic diseases, autoimmune disease, even the obesity. They have focused that the obesity probably major role is by the change in the microbiota in the intestine. And probably that is likely due to this overuse of the antibiotics. So we are probably not helping, we are creating long-term permanent damage to the child. And what even we are doing the damage to the community? Uses of antibiotics in the individuals, which develop the resistance, and these resistant bugs spreaded in the community as already Dr. Urvesh was talking. And that resistant bug in the community is most dangerous. Our antibiotics may not work at all. So please keep in mind, as I was talking, that is very important. We have to remember our oath. I may not be able to help the patient, but with the knowledge, I cannot damage the patient. I think that's very important message which we have to keep in mind. As a clinician, please ask these questions to yourself before prescribing the antibiotic. Is it infection or something else? If it is infection, is it bacterial or viral? You know that most of the infections are viral. Bacterial infections are less comparatively. Once you decide, yes, it is bacterial, then try to find out either they confirm by the culture, in the case of enteric, as already Atul was talking, or at least your epidemiological understanding that what is the likely organism. Is it serious or problematic, or I can wait? Accordingly, what is the site of the infection? And accordingly, try to find out the appropriate narrow spectrum antibiotic. And then decide that is there any comorbidity or something. Keeping in mind all the points, prescribe the antibiotics. Not just simply whichever comes to my mind, or whatever the recent or new antibiotic has come. Not necessarily new antibiotic is safe and effective. Maybe sometimes even the more damageable to the child. Please, friends, what message actually I want to convey to all of you. Be the good clinician, master clinician. And I'm sure that on the clinical ground, only try to decide, should we go for the antibiotics or not? And I may not be able probably to make the decisions in all the fields. But yes, certain fields are there. And as a practitioner, probably you can make up your mind where you can focus to decrease the overuse of the antibiotics. Number one, watery diarrhea. Tomorrow only, I think, try to define that only acute diarrhea disease is the watery diarrhea or fever, cough, and rhinitis. They are never going to be the bacterial. I'm not going to prescribe the antibiotics. We take the oath. I'm sure that probably this discussion is going to be the most useful and most effective one in our daily practice. Already, Atul was talking is right that the throat infection is overdiagnosed. Younger the child, even the throat infections are viral. They are not the bacteria. Bacterial infections will be common after 3 to 5 years. And even if you miss the bacterial infection, probably there is no harm. So don't unnecessarily upper respiratory infections and diarrhea prescribe the antibiotics. Wrong agent, as already I was talking, cefixime is not for the respiratory infections. Cefixime should only, in the pediatric practice, should be for the dysentery, enteric fever, and urinary tract infection. Delayed use, not practiced, particularly as I was talking, acute enteritis media. And even if proper use, underused drug is the amoxicillin, particularly the pneumonia. I think in the acute otitis media, even if you diagnose acute tonsillitis, if you diagnose pneumonia, all the conditions can be treated masterly with narrow spectrum and very good drug, effective drug, amoxicillin, if at all it requires. I'm sure that just if you focus over this, my presentation of this particular slide, and decide not to prescribe the antibiotics in watery diarrhea, and the patient with the high-grade fever and the rhinitis, I'm sure that automatically the antibiotic rate should come down in our OPD patients. Long back, I received this, I will say, on my WhatsApp, and I saved it. I like it. That fever is not a sign of the ceftriaxone deficiency. Fever is not the deficiency of this azithromycin. And every fever is not necessarily a bacterial infection. The point is, reflexively what we are prescribing every patient with the fever, the antibiotics are not the right answer. And I'm sure that just if you go for the analysis, I'm confident that the rate of the antibiotics should come down in our OPD. Friends, what I wanted to share with you. Documentation of fever is very important first. And then think that the fever is due to the inflammation. Every inflammation, not necessarily infection. An infection, every infection, not necessarily bacterial. Mostly it is viral. And once you say viral, probably they don't need the antibiotics. And please remember, antibiotics are not antipyretics. For fever, you can offer the paracetamol. Not necessarily every patient with the fever should get the antibiotics. This is very important. And once you decide documentation of fever, if localizing, you can start the antibiotics. If not localizing, wait for 3 to 4 days with simply paracetamol, document properly, and fever without the focus, collect the sample and start the antibiotics. But here, define the indication, proper choice, and hardly change of antibiotics are required. Very few patients will require the combination. I think it should not be the reflex prescription in our daily practice. Thank you very much, friends, which I wanted to share with you. The point is, avoid the antibiotic abuse. I think antibiotics should not be taken lightly, and you must be knowing, since last several years, no new antibiotic is coming up. And what you will do in the future. You must be aware that even Hinduja Hospital, Mumbai, there was reporting that diagnosis of even the tuberculosis adult patients, acid-fast bacilli are diagnosed, but resistant to every drug available. Simply, they could just watch the patient dying, could not do anything. And probably these days are not far away unless we change our behavior. And I'm sure that this discussion, the celebration of this week or day, will be fruitful if we at least change something in our behavior. And I think if we do so, that is a great contribution in the development of the country as a whole and in the community. And I'm sure that that will be the success of the celebration of this day. Thank you very much, friends. I end over here. Once again, I would like to express our gratitude to the organizers for giving me this opportunity to share my views with my dear friends. Thank you very much. Thanks a lot.
Thank you so much, Baldev sir, with your for your enlightening session.
I think Vipul's connection is lost.
Yes, I think.
Should we take questions? There are some questions in the chat box.
I think there are few questions.
Yes.
We can see in the chat box, but few of the questions already been answered by the Atul sir as well.
Okay.
But a few questions just I wanted to highlight by the Dr. Ravin Panchal, Dr. Vaibhav Patel. One question was raised about the ferropenem. There is a increased frequency of the use of the ferropenem. How will you address these things? Even in UTI and because it is considered as an alternative as alternative oral carbapenem. It is something like that. Atul sir, how will you address this?
So actually, this is misnomer that it is oral carbapenem. It has nothing to do with the carbapenem. The name is just similar to meropenem and ferropenem, right? But it has nothing to do with the carbapenem. And the biggest issue that I can see with the ferropenem is like we do not have good studies in clinical practice to support the use of ferropenem in any infection, right? Except the ferropenem has been studied in Japan for respiratory infections, but otherwise, like we do not have any evidence that this drug is useful for XYZ infection. Why this is important? Let me give you an example. We know that like vancomycin is excellent drug for staphylococcus, right? Everybody agrees. Nobody can, doubt or nobody can, debate on that. But if I'm using vancomycin for treatment of methicillin-sensitive Staphylococcus aureus bloodstream infection, and if I'm using cefazolin or cloxacillin for treatment of the same methicillin-sensitive staphylococcal bloodstream infection, so what do you expect? Like, what would be the response of vancomycin and what would be the response of either cloxacillin or cefazolin? Just tell me. If you are treating 100 patients with vancomycin and 100 patients with either clox or cefazolin, how many patients on vancom will improve and how many patients on clox will improve?
Definitely MSSA. So the first choice will be cloxacillin.
No, just tell me the numbers. So that will clarify like how to interpret the ferropenem.
For our findings in records, are you talking about the prevalence of the MSSA, right?
No, bloodstream infection with MSSA.
Bloodstream infection with MSSA.
Bacteremia. I'm talking about bacteremia.
Bacteremia in hospital setup.
Any setting. You are giving vancomycin in 100 patients and cloxacillin or cefazolin in 100 patients. So how many? Yes, sir.
I may not be able to say the percentage, but the point is, in MSSA, vancomycin is inferior to these drugs.
Exactly.
It's inferior.
Exactly. That is what I wanted to share with all of you. We believe that vancomycin is excellent drug for gram-positive. But if I'm treating 100 patients with MSSA, only 60% will have response to the vancomycin, even though you are giving ideal standard weight-based dosage. And 90% of the patients who receive cefazolin or cloxacillin will respond.
True.
So this is how you have to select antibiotics. It is not that this drug has a spectrum, that it can take care of staphylococcus, it can take care of methicillin sensitive, methicillin resistant, but it is in vitro susceptibility. But when you look into the actual clinical practice, the figure is different. So always try to find out a supportive document that this drug is being used in urinary tract infections and what was the results and what was the outcome as compared to the current standard of the care.
Right.
Just in a lighter mood, in our practice also, big names with not necessarily the good treatment. So similarly for the antimicrobial agent also, recent one, big one, name one, covering so many things is not necessary. I think good example Atul Bhai has given, and many a times even I will say most of our friends are having this impression that even the staff they are knowing, then they say that the vancomycin is going to work masterly. but not necessarily.
It will not, yeah.
It will not. On the contrary, MSSA, then definitely it is inferior to these basic drugs.
Exactly.
I think very important and good message. Regarding the pharopenem in the pediatric practice, number one, it is not permitted to us even to use legally. And second, even not, as Atul is telling, I was not sure in the adults, but the children also, it had not been studied and not defined the exact uses. So I think I request the pediatricians, please remain away from this drug.
Yes, Dr. Mitul.
Yes. Sir, one of the questions is, can you elaborate on antimicrobial audit in your setup?
So we regularly do the antimicrobial audit in our hospital since last couple of months. Like we are not doing it regularly because of several other issues. But what we do, like we try to keep a record of the restricted antibiotic that the consultants are using. So with every PNT committee meetings, PNT is Pharmaceutical and Therapeutics Committee meeting. So we try to identify like how many vials of colistin, tegacycline, or all the antimicrobials like meropenem, cefazolin, cefoperazone, sulbactam, piperacillin, tazobactam, or antifungals has been used during the previous meeting and the current meeting. And we try to find out like what are the gaps by where the clinicians have not used it properly or it was used inappropriately. This is number one. This is how like we try to keep a record and analyze the data on antimicrobial use in our hospital. The second thing that we do in our clinical practice that we have stopped since last few months because of other reasons, that we try to, consultant will have to fill a form, a simple one-page form, when the consultant is prescribing either tegacycline or colistin or any other broad spectrum antibiotics empirically. Then the consultant will have to mention that he has started this therapy for this clinical indication and he has submitted this cultures, either blood cultures, urine cultures, or CSF culture, whatever, like he has a clinical suspicions. And at the end of 48 hours, like the form is revisited by the hospital infection control nurse and try to collect the reports of the cultures that patient was, requested, and try to match whether after getting a culture report, whether consultant has de-escalated the antimicrobials or revised the antimicrobials.
Right.
I think regarding this antibiotic audit point of view, those who have probably studied from the Department of Pediatrics, BJ Medical College of my age must be knowing that every Monday we were doing the discharge case discussion, which at present I am doing in the GCS Medical College every Monday. Last week, whatever the numbers of patients we discharge, unit-wise the registrar with the presence of the faculties will give the account that on which ground we diagnose the entry, and then which antibiotic we have chosen, how it is worked. And even this works in a very many times, and even I would say probably before this COVID, one of our paper was presented, what is the antibiotic rate in of our indoor patients. And that we compared, and let me even confess over here, it was significantly high in our own department. But from this study, we came to know that we can do something to restrict it. And I'm sure that in a long way, it pays. Here, Dr. Uveshi is there, and under his leadership in our GCS Medical College, the restricted antibiotic usage form is there, as Atul told. And I think this is uniformly in most of the institutions, they wish that we should have that restricted antibiotic use, at least by filling up the form and follow-up, it makes difference. I'm sure even again, I will say probably it is not still satisfactory, but at least we are doing it this way, and definitely this type of audits are quite helpful.
Right.
Thank you so much, sir. One of the question is, can you, sir, give more insights on lateral flow or rapid test, which you already mentioned in your talk, in context with OPD and the respect to disease diagnosis and its associated cost?
So, the rapid diagnostic tests are extremely important, right? Because it helps the clinicians for reaching an early diagnosis reliably. And for the family practice, like the important rapid diagnostic tools that is available to you would be the influenza test, COVID test, and the group A streptococcal antigen test. So these are very commonly used in general practice. But the other rapid diagnostic tests, which are very important and generally used in patients, are most of these are related to the fungal infections like histoplasma urinary antigen, lateral flow assay for diagnosis of invasive aspergillosis, lateral flow assay for the diagnosis of cryptococcal infections. Lateral flow assay is also being developed for the diagnosis of the fungus, which is not common in India, that is the coccidioidomycosis, and lateral flow is also being devised for Penicillium marneae infections. So, I mean, these are the very important tests where you do not require any hi-fi laboratory setup. It is just a pregnancy test like kit, where you have to apply a drop of serum or drop of CSF, or if you are conducting a urinary antigen test, you can put the drop of urine. I forgot about the pneumococcal infections. So we do have the urinary pneumococcal test, which is, again, it is not a lateral flow assay, but it is a rapid diagnostic test. And we also have a Legionella urinary antigen test. So if you have a clinical suspicion of invasive pneumococcal infection, you can very well diagnose by putting a drop of urine into this kit. And within 2 hours time, you will be getting a confirmed diagnosis of streptococcal infections, Legionella, or other infections, right? And the cost, yeah. So cost, it is not that expensive. Cryptococcal test is ranging around 800 to 1200 rupees. Histoplasma test is little expensive, but the Indian kits is again in the range of 1000 to 1500 rupees. The cryptococcal, histoplasma, and aspergillus. Aspergillus is also 800 to 1200 rupees. So it's not that expensive.
Right.
Urinary pneumococcal test, sir?
It is also like around 1200 rupees.
Okay.
The only one point which we should keep in mind, that certainly these rapid diagnostic tests are quite useful. And as Atul Bhai said, that even if the support patient comes odd time, or even some immediate investigation not possible, even for the early diagnosis, even appropriate treatment you can start early, and by that also the antibiotic usage can be avoided. The only thing that the appropriate kit should be available, the standardized kit should be available. Many times the practice it is seen that every kit is not standardized. And then what happens that the results may not be reliable. In that case, that precaution we should take. And in that case, pediatric practice, this is known, Mithun, because you are asking, urinary pneumococcal antigen is not that useful in pediatric practice. That is even documented. So on the contrary, you may get the falsely positive, and that may even misguide you. So it is even stated that this state should not be used in the pediatric practice.
Right.
Great, sir. With this, we come to an end of our question and answer session.
One question from my side. What we can do to stop sale of antibiotic by chemist without prescription, or on prescription based on last month or previous day?
Yeah.
Many mothers are doing this, or chemist selling without any fear. So this is most common problem in every routine practice.
So I think government should come out with the policy.
Yeah.
Until I think
enforce, just like traffic, the rule, they should enforce these pharmaceutical rules that you cannot get the antibiotics without prescriptions.
Unmesh, I think you can try to educate the parents and even the people, whatever at least little bit we can contribute. But otherwise, what Atul Bhai said, that absolutely to implement the law is the only answer.
And yes, sir, I was also discussing with you at Kerala and UP government already has a legal antibiotic stewardship program. So I think Gujarat government should not stay behind in this matter.
Yeah, exactly.
We will work on that.
Yeah.
And AMS should be enforced. Like in Stirling Hospital, I got several calls when we have stopped supplying quinolones. So almost all clinicians, they try to call me, why you are restricting my levofloxacin to my patients, like I'm having some bone and joint infection or something like this.
Yes.
So, but I mean,
by forcefully,
at the end of first few months, like everybody, realized that this drug should not be used, and the people were using the other alternatives for the treatment of their infections till now.
I think these things are going to happen. Let me share one at my own place, TCS Medical College, in our department. As I was talking that we are doing for the discussion, but my faculty met to our director, sir. That, sir, to discuss these things in the presence of resident becomes difficult. This was the thing. I talked to my own friends that this is not the point of finding out the fault, not to criticize anybody. Yeah, probably all of us, even we are doing. Sometimes even I will say as a senior person also, I may be wrong, and we can point it out. Or sometimes every time there is no question of right or wrong. Due to some situation probably you have chosen. And therefore what we can do, it is my habit even the regular round, that I may not be able to answer them that why I'm starting the antibiotic. But I hear, suppose I have to start it, then I will put the note that having this condition, the high-grade fever, these are the points favoring the bacterial infection clinically, and these are the findings. Here the possibility of bacterial infection is very high. We are not able to at least prove. And therefore, even we are starting the antibiotic over here, but the justification is in the form of that is the thing that why we have started.
Absolutely.
And it is possible that next day or third day something else comes, even we'll stop it. True. So I think we can put it, but this happens, as Atul said, I will appreciate him that at least they could convince the people in the institution to stop it. True. And we can. And we know that once we do something like this, it is definitely some resistance is going to be there. As I said, my own faculty, even, they didn't talk to me. They went to the director, sir.
Sir, major work we need to do on OPD practice.
But then they realized, and now they are doing very well.
In OPD practice, there are lots of the antibiotics being prescribed in CT-based practice, right? So we also want to work on that, and definitely I have a talk with the Dr. Tushar sir. AMA will work on that, and with the help of all of you, we may present something to government. We'll see that.
Yeah. I think, Dr. Lewis, simply as a practitioner, I think that it's very loud and clear message to all the friends who are listening to us. Simply they decide, I think there is no hesitation to us. Watery diarrhea or even the cold and rhinitis, you are not going to miss the bacterial infection. At least stop the antibiotics in these two conditions. At least we are very safe. I'm sure then also there will be some action will be there.
True.
I guess we are done with this question and answer session, and I'll appreciate Dr. Pragnesh Vishwajani sir if he can give a vote of thanks.
Thank you, everyone. First of all, Baldev Prajapati sir and Dr. Atul Patel sir for sparing your valuable time on this very important subject, which we come across on a day-to-day basis regarding this overuse of antibiotics and the antibiotic resistance that is already there and looming to a very large extent in future. And I will thank Ahmedabad Medical Association as well as Academy of Pediatrics to join hands with Swasthya Setu in this education initiative. And I will thank all the friends and the colleagues who have already joined and watched this webinar in large numbers. And I will request all of you, those who have attended this webinar, kindly circulate the same link to your colleagues who could not attend because of XYZ reason, because this is a very important webinar to attend, and that is for our future as well as the future of the society. Thank you everyone on behalf of Swasthya Setu and on behalf of Ahmedabad Medical Association and Academy of Pediatrics. Thank you all the viewers for joining in today's program.
Yes, thank you very much.
Thank you.